Okay, picture this. A patient, third trimester, suddenly starts bleeding, but there's no pain. This is a classic, high-stakes medical emergency, and knowing exactly what to do can literally save lives. In this explainer, we are going to break down placenta previa from top to bottom, from diagnosis to management, in a way that's going to stick.
So here's our game plan. We're going to start with that classic clinical sign, then get into the anatomy behind it, and then walk through how you diagnose and manage it safely. And of course, we'll wrap it all up with a super high-yield review.
All right, let's dive right in with a clinical scenario. This is the kind of thing you're going to see on your exams, and more importantly, in the real world.
When you hear that phrase, sudden, painless, third trimester bleeding, that should be a giant alarm bell going off in your head. It points straight to one critical diagnosis you absolutely cannot afford to miss: placenta previa.
So what is actually going on inside the uterus that's causing this kind of bleeding without any pain? Let's take a look at the basic anatomy of the problem.
It really just comes down to location, location, location. The placenta, which is the baby's entire support system, has set up shop in a really dangerous neighborhood, way down low in the uterus. It's sitting right on top of the cervix, literally blocking the only way out.
And here you can see that difference so clearly. Look, in a normal pregnancy on the left, the placenta is way up top, totally clear of the cervix. But with placenta previa on the right, it's covering that cervical opening, the os. You can immediately see how any stretching of the cervix later in pregnancy could cause that placenta to tear and bleed.
So who's most at risk for this? Well, a previous C-section is a big one. Any scarring on the uterus can kind of encourage the placenta to implant lower down. Having had multiple babies, being a bit older, or carrying twins or triplets also bumps up the risk. And, if a patient has had it once, they're more likely to have it again.
Now, it's really important to get this. Not all cases of placenta previa are created equal. The severity is all about how much of that cervical opening is actually covered by the placenta.
We basically break it down into 4 types. A low-lying placenta is close but not quite touching the cervix. Marginal means it's right up to the edge. The danger really starts to ramp up with partial previa, which covers some of the opening, and then complete previa, where the entire exit is blocked. That obviously is the most dangerous situation. Okay, so we understand what it is and the different types. How do we actually diagnose it confidently while making sure our patient stays safe?
Well, the diagnosis really starts with that classic clinical picture. You're looking for that triad: painless, bright red bleeding in the third trimester. And when you feel the abdomen, the uterus will be soft and non-tender. That's a huge clue that separates it from something like a placental abruption, where you'd expect a rock-hard, painful uterus.
Now, while all those signs point you in the right direction, there's only one way to be sure. The gold standard for diagnosis is an ultrasound. It's the only way you can safely see exactly where that placenta is without causing any more problems.
But wait, before you even think about doing anything else, there is one absolute non-negotiable rule. A life-saving contraindication that you need to burn into your brain forever. So let me make this crystal clear. If you have even the slightest suspicion of placenta previa, you do not, I repeat, do not perform a digital vaginal exam. Poking around in there can literally tear the placenta, triggering a massive, catastrophic hemorrhage. It's one of the most dangerous things you can do. Okay, so you've done everything right. You've recognized the risk, you've confirmed it with an ultrasound. Now what? What are the next steps?
Your management follows a really clear decision tree. The very first question is always, are the mother and baby stable? If their vitals are good and the baby is still preterm, we can often manage conservatively. That means bed rest and very careful monitoring. But if there's heavy bleeding, if the baby's in distress, or if the pregnancy is at term, there's no waiting. The only safe option is immediate delivery, and that is almost always going to be by C-section.
And this management is so critical because, well, the stakes could not be any higher. We're talking about the risk of a massive hemorrhage that could send the mother into shock, a dangerous preterm delivery, or the baby suffering from fetal distress because its oxygen supply is compromised. All right, let's lock all this in. We're going to do a rapid-fire review of the most important, high-yield points you absolutely have to know. Now, this is one of the most common exam questions out there, telling the difference between previa and its evil twin placental abruption. Just remember this. Previa is painless, bright red bleeding with a soft uterus. Abruption is painful, dark bleeding with a firm, rigid, tender uterus. If you can remember that, you are golden. And here are the 5 takeaways you absolutely cannot forget. 1. The placenta is in the lower uterine segment. 2. It presents with painless bleeding.
3. You diagnose it with an ultrasound. 4. No digital vaginal exams. Ever. And 5. The definitive management for serious cases is a C-section.
And that's your guide to placenta previa. So the next time you encounter that classic sign of painless third trimester bleeding, you'll know exactly what to do. And maybe more importantly, what not to do. It's one of those conditions where thinking quickly, calmly, and correctly really does make all the difference.